Next, we're going to have a panel discussion on quality improvement and malpractice prevention. So Dr. Chris Karras, Dr. Oluoch-Olunya, Dr. Galler, and Dr. Okoth, please come forward.
Yeah. Go with the disc.
That would be a distraction. I just is what I like today.
We're just going to start off by introducing yourselves and who you are and where you work.
Good morning. I'm David Oluoch-Olunya, practicing neurological surgeon from Nairobi, based at the Nairobi Hospital. I also consult at the County University Hospital, and I'm a board member at the Oluoch-Olunya Teaching and Referral Hospital.
I'm Dr. Peter Okoth. I'm the CEO of Oluoch-Olunya. I'm a dentist. I'm a health economist, and also business administration.
My name is Robert Galler. I'm a neurosurgeon from New York. I work at a large healthcare organization called Northwell. I'm the director of neurosurgery at Conn Bay Medical Center and the director of spine for the Eastern region of the system.
I'm Chris Karras, a neurosurgeon from Ohio and Dr. Oluoch's partner at Grant Medical Center.
Okay, so we'll start with Dr. Oluoch-Olunya. So how does your hospital ensure quality, or how does that work at your hospital?
Thanks for that question, Dick. You said my hospital. I mentioned a few hospitals. So
how do your hospitals?
I think the one which I'm most concerned about here is the Oluoch-Olunya Teaching and Referral Hospital. I have the privilege of being recently put in charge of quality when I got on the board. So one of the things that we discussed with the CEO is really benchmarking. I think what we looked at is what is best practice, and best practice isn't being measured by us. Best practice comes through what is published. We know what figures should be in terms of inpatient, outpatient outcomes, infection control, and so on. So what we're in the process of doing, and I think this is work in progress, is to be able to see where we are in terms of patients coming through, the markers for in-hospital stay, time in the operating room. Since the Sumo Neuroscience Initiative has been working at the Oluoch-Olunya Teaching and Referral Hospital, one thing we've introduced has made a big difference, and I think we got the message from the operating room here, the theatre checklist. It's something simple, but it has made a big difference. And it may sound obvious, but you have to know that you're operating on the right patient, on the right side, for the right condition, and on the right level. It sounds very clear. Pilots have been doing this forever, but we've had one of the few concerns in the country where mishaps have occurred. But that's one thing which we started last year. And I think as time has gone on, it's now part and parcel of how things work. So to come back to your question, it is really looking at best practice and trying to make sure that's incorporated in the system.
So who collects data, for example, at Jaramogi Oginga Odinga? Who collects the data on post-operative infections and stuff like that? Would you be able to say, last month we had
streamlined, and the record keeping system, I think we discussed it with the CEO, we should be able to track it. At the moment, it's all paper driven, and it's put in the records office, so it is done retrospectively. But in the operating theatre now, the indicators, the nursing staff fill in forms to state how the patients are coming and what procedures are being done. And I know within the information systems that are coming in, we'll be able to do so this coming year.
Statement and specifics. I want to state that quality, we have a quality improvement team in place, all specific. A lot of work is being done to ensuring that we move forward with the quality. But I want also to state that the method of providing reimbursement, especially when it comes to financing, has very significant impact on movement towards quality, because then it provides the incentives what that quality coming. And we want to look at quality again broadly, because quality means timeliness of service, quality means the efficiency that are there, and of course safety and all that. Now, factoring on safety, which Dr. Oluoch has dealt with, is the checklist. Now, the problem we are having is the implementation side. These things are there in terms of what needs to be done, briefing, signing in, setting up, checking out, signing out, and debriefing. They are there. The problem is the implementation. And what I also observed that the change management is quite a big problem among especially the older people. When now the other comes in, but if it is led by the more experienced, then it becomes much more easier. So yeah, that's the observation.
Thank you. I mean, just to comment on the timeout process, I know the first time I was here, I stopped to do a timeout, and everybody kind of looked at me like, "What is this guy doing?" You know. So I think this time around though, everybody seems to it's become part of the process. So it's good to see even those simple things, make a big difference. So it's good to see that some things have changed since the first trip that we did. Any questions from the audience? Anybody have a question about quality or malpractice prevention?
I would just like to add that with the timeout process and the things that I've encountered being here, I think the key for the folks here is going to be that these should be physician-led endeavors. And I think that one of the things that I've noticed that the staff really embraces is when the doctors absolutely are on board on that team. Physicians are very difficult people at times. We don't like to adopt new methods, especially if we're a little older. We get a little set in our ways, and then someone tells us we have to do it a little differently. It can become difficult. I can tell you at home, the timeout process is extremely extensive, and when it became part of our operating room procedure, many of us kind of felt like this is just a waste of my time. I would like any of those physicians to come here and tell me it's a waste of time. It's enormously important, and I think that all of us that are visiting, we do the timeout knowing how important it is. And I think that the staff kind of gets that, and so for any of these measures that are taken to improve quality, whether it's determining the checklist or monitoring for infections or things of that nature, if the physician's championing it, the rest of the staff responds. I think that would be the only advice I can give to the residents and the physicians here, because these are new things, and it's effort, it's extra effort, it's things that don't necessarily have a monetary tag on. You're going to have to work a little harder than you were to do the same amount, but at the end of the day, you'll get those improvement features as a result.
Thank you. We had a question?
Yes, sir.
I don't think the mic is on. And if you would, please just introduce yourself. Go ahead and introduce yourself before the question, please.
Yes, my name is Zahim. I'm a neurosurgeon from Nairobi. I work with Oluoch-Olunya sometimes. But I also have a private hospital where I normally practice. Now, malpractice and litigation, I mean, no training is a key to everything, and having the proper instruments, because if you are trained and you don't have the proper instruments, you're probably not going to do a good job. So I think that is key, and especially for our emerging hospital. The contents of such kind of meetings where here and there, and so I think that is important for all of us. And just a question that I'd like to ask this guy from Ohio. Sometimes in 2004, 2005, I did that fellowship in St. Louis, and Ohio was not the place to go because of litigation. I wonder how you have gone, how that you practice there. I don't know how you have managed to go about that. But, and what can we learn even from us from here, from what you guys have done?
So you're right that Ohio was one of the worst states for malpractice litigation. And each state has different laws that apply to how malpractice is applied. And that continues. So malpractice insurance, if you're in private practice, is the average in Ohio $150,000 a year. So $150,000 has to be collected just to pay malpractice. Mostly trauma, mostly indigent population, mostly emergent neurosurgical procedures. The risks are increased significantly for malpractice. In 10 years, though, we've had no suits against us. And it's not because we're doing the best job. It's because the hospital is doing the best job of shielding us. And there are multiple ways to do that. So, yes, there are attorneys available at the hospital. There are legal processes that assist with that. But the reason that this panel discussion is labeled quality and malpractice litigation is because you have to have a certain level of quality at the hospital in general for an individual surgeon to avoid malpractice issues. You can't on your own control all the factors. In fact, many times we are concerned because we think a lot of the malpractice litigation is due to something that we had no control over. How was the wound cared for afterwards? How was the ICU managing the patient afterwards? What equipment was available to us in the operating room for this emergency procedure? These are things not in our control, we think. But they are in our control. And what we have at our hospital in general in the United States are what are called CPIT, C-P-I-T. That's Continuous Process Improvement Team. All of those letters in the acronym are extremely important. So you can have this general theme of wanting high quality at your hospital, but there has to be a functional way to do it. There has to be an operational way to make it happen. And the way we do that is we atomize it. So every small group in the hospital, every specialty, the oncologists, neurosurgeons, neurology, trauma, have a CPIT. It's continuous. They meet every month. It is process improvement. The goal of the meeting every month is to improve whatever processes are in place and add new ones if necessary. And then T is team. There must be 15 or 20 people in every meeting. And it's because it's not just a neurosurgeon that's going to make the quality better. I can only do so much. I'll make sure I scrub properly. I'll make sure I wait for the betadine to dry. There are only certain things I can do. But the other 15 people in the room are responsible for wounds, for administrative issues that may arise, for equipment, for financial things. And so this meets every month, and everybody in the room has ideas on how to make the process for that one small part of the hospital better. And unless you do it continuously, the habits fall away. How are things documented? that has to be part of a continuous process improvement. There have to be a team of people creating that process. It can't be a nurse. We don't know how to create that process. But we can tell you where it fails for us. The nursing can tell you where it fails for them. So that CPIT, I think, is one of the most important things in actually making the quality changes. And those quality changes shield you from malpractice. In all the parts of the hospital that affect your patient, you will be open to malpractice issues.
Thank you. Any other questions?
Over here. Hi, my name is Rebecca. I'm a circulator and nurse.
Is the mic? Go ahead.
Okay. It's a little while. My question or my input to this in observing in the hospital and participating here, we saw two areas. In the timeout area, and it's great that you are doing a pre-incision timeout. We include a timeout with anesthesia at induction. And it includes the team, and they participate in having everybody on board when the patient comes into the room, they're getting ready to go to sleep. We do a timeout with anesthesia just to make sure we have all the safety checks, the right patient, the right procedure, and what they need in the room for induction. It seems that what I've observed at the Anesthesia Act, it's like a parallel process. They bring their patient in, the team is working in the room, but there is no acknowledgement between. And it's essential because, as we know, induction is like a very dangerous potential time for a patient. So it would be, I would suggest to include that in the timeout. Also, our timeouts, because they are surgeon or attending driven, we laminated a form, and I don't know if that's a possibility, but it keeps the form clean. You can mount it on a wall. It's an acceptable standard. And at all the important notes that have to be addressed at each timeout are there. So the surgeon or the attending anesthesiologist can look up, know exactly what he's addressing at every moment through that timeout. So we're not prompting him, we're not leading it for him, that they're an active part, but everybody's aware. That was the one part, that's the one thing I would address in timeout. The second thing in quality and improvement is the processing of instruments. So there seems to be, they're doing the job that they can with what they have, but the items that are coming out, as cleaning the items, it isn't the best area. There's buckets on the floor, and I know that's all that's available, but there are exchange buckets, which is a good thing, and they're hand washing. The second part of it is when they put items in an autoclave, they don't have shelving in their autoclave. So everything's piled on top of itself. So yesterday we experienced a lot of wet items, wet cloth coming out. So that, that takes away sterility. So the simple things that we could do to make sure things are clean and sterile, that we would eliminate any contamination of anything, that would be one of them. They just didn't have shelving in it. They were using it, the things were wet, and there was, they did the best they can. I'm trying to look at the most simplest things to make things the safest for the patient. And that was the other item. Also, the way that the cleaning technique is done. Everybody needs to be on the same page, how they approach a room, how they clean that room from before the case to the end of the day. There's a little bit of exceptionals in that no one follows the same process. They would be the basic things, and maybe hand washing, the way you would come into a room. We were teaching our scrub techs, the first assistant, our scrub. We're teaching the students and the staff coming in. They would wash their hands, come in sterile, and then open gowns without having everything open prior, having your sterile gown open, your gloves up. They would come in thinking they were sterile, can open their package, then put their gown on. So simple, 1, 2, 3 steps that could be processed and followed, that everybody would follow the same thing. It probably would help someone.
Thank you. To Dr. Okoth and Dr. Oluonya, maybe you can answer this one for me. Is there a peer review kind of system in the hospital, and how do you deal with, let's say, a particular physician quality, or if there's something that's questionable, how do you go about, is there a peer review system, or is it a different system how you deal with quality issues from individual physicians?
Let me take this. Yes, we have a system of peer review and peer review, and that's generated from particular areas, the division of medicine, division of surgery, and various divisions in the hospital. And this we formed for the last 3 years. We've been running a professional ethics and integrity committee. It takes a lead on that. We meet every month, whether there is an issue at hand or there is no issue at all. They look at the processes and concentrate on areas that probably are brought to that. We know that 50% of malpractice cases from literature and even from our observation emanate from issues around the operating room. And those are given due consideration.
Good morning, everyone. I'm Dr. Vincent Honko, currently a Okoth Year 1 resident at UTRH, a strategic management practitioner and a budding healthcare public healthcare practitioner. Thank you, Professor Oluonya. I'm happy to know that at the board level now you're spearheading the quality at the UTRH Center. My CA is here. Dr. Okoth, as my senior in strategic management practice, you know that the concept has evolved to strategic quality improvement. At UTRH, we have an integrated holistic strategic quality improvement plan, and we know that it's client-centric. There are specific champions that have been identified to drive this. Dr. Karas has talked about the CPIT, which is also very important in driving quality. Is there a CPIT at UTRH that on a monthly, quarterly sits to review this? I'm happy that you noted that 50% of our quality gaps obtained from the surgical practice. Is there a team that sits down based on head data to drive our quality improvement? Thank you.
Yeah, we have a quality team that reports directly to the office of the CEO and the board. At the board level, we have a quality team too. Now, the quality team the quality management team cascades up to the departments. At the department level, we have work improvement teams that consistently sit on, every month and gives feedback. So there is a specific organogram just for quality and how distributes the information. The other observation that I want to make is that when we're also looking at the quality, we need to really factor in the issue of interpersonal asymmetry. 80% of the patients that we are seeing are mostly from poor background, of course, because we are public hospital, and there's usually a tendency to treat quality issues less. If you have a big gap between the provider, because of the nature of the profession, between the provider and the consumer, you are likely to have more quality issues when the distance is bigger or longer than when we have, let's say, in private. And therefore, the only problem that again is there, because people are less likely to raise these issues. So we are the custodian. So it's important that in public sector we have stronger policy teams. That's not to say that we should have otherwise in private. Now, as you even go to much more subspecialty like neuro and that, in the research becomes much longer. So that vigilance need to do that. I don't know if I have answered the question.
We'll take one more right here.
Thank you. I'm Dr. Ikuya, a neurosurgery resident from Uganda. My question is how to balance I don't know how you define malpractice, to balance malpractice and good intention in the law setting, whereby you know that this is wrong, but this is what you have to do because the setting is really limited. Thank you.
Thanks for that question. You're working in Malawi, are you?
Yes.
Right. Now, knowing that this is wrong and that's what you have to do, in a resource-constrained environment, the caregiver is at a quandary, there's crossroads. Sometimes you have to make a decision as to whether this is going to be life-saving, this is going to be enough to avert a disaster, and yet you do not have the tools to be able to do so. The corollary to that is if you do not do anything, there will be a disaster. Malpractice, the basic of it is there has to be a reasonable body of people who say in that situation, would they do something similar or not? There are standards of care. I'll give an example. If you are out very far from any institution, a classic one was a story for somebody in the outback in Australia, and somebody had a pupil which was dilating, and there was a body swelling on one side of the patient's head. All he had was a Black & Decker drill, and he made a decision, and he compressed whatever bit of the epidural hematoma was there, and the patient was saved. I had the privilege of working in Scotland. Scotland, everything in Scotland is all good and everything is good. Outside the islands and highlands, you just have a general practitioner and you need a boat to be able to get to land. What the general practitioner did, was somebody had never done it before. He did a skin incision, cracked open the skull, took out the hematoma, and he packed it with gauze. If you leave that in the WTRH, you do so. But the fact that you're out in the periphery, you did a life-saving procedure with what you had available to you. Nobody was applying. But in our system here, this last year, for example, in neurological surgery, we now have drills. The hospital has bought. There's a drill that we brought through from the Kisumu Neuroscience Initiative. So the standard of care to open a craniotomy is to use a drill, not use a jigsaw and or buckles. But if you didn't have the power tools, you'd still be able to get in. So now, if the people dilated and you get in quick enough, the fact that you have the power tools, that may be cut against you. So to come back to your question then, if you are in a resource limited environment, then the standard of care, not that it is lowered, but if you are in a life-saving situation, you really have to adapt with what you have. Yeah, so when you're saying something is wrong, the person in the outback who used a Black & Decker drill, when you did it for the patient life was saved and was able to be looked after. But you cannot use a Black & Decker drill and tell them what you need. I hope that answers the question.
Yeah, if I may just add also, we have also to again review what are the incentives that are there in the system to help address procedural issues. What are things that probably make us not to refer when it is appropriate? What are the things that make us hold on to the patients without consultation? So these are the things that need to be addressed, because then when a decision is made prior that okay, it's a good intention. What are the implications of these good intentions that probably may not have been mitigated by appropriate consultation and all that are there. But as far as procedural issues, there are what are the issues that lead to misdiagnosis? Do we exhaust consultation and timely referrals?
And I would just like to add, before we wrap this one up, one more thing, that if you have a team of people meeting about quality, it cannot just be what we call the C-suite or the executives. It cannot be just the physicians getting together. You have to ask everybody at every level to weigh in on how is the OR functioning. We're going to have an operating room CPIP. We're going to have a nursing ward CPIP. But if you don't involve the person who also mops the floor, the person that pushes the bed, it can't just be the CEO. Paul should be there too, the guy that helps us in the OR. If he's not there, those details that no one else sees, that he knows I can't push the bed around this corner, those things make a big difference. Those things make the daily difference. Those things start to make the operating room, the ward, look better consistently. So I think you do have to make sure you involve everybody at every level in those meetings, or you will miss a lot of the most important things.
And to add on to what Dr. Karras said, you see a lot of times people will come up with these really bizarre quality implementations that you look at and say, who came up with this? Yeah, it was because a bunch of people who are not in that specialty were meeting somewhere, discussing or creating quality measures for something they're not involved with. We see that in our operating room all the time. The people that sometimes are making some of the decisions aren't in the operating room, but we should invite them once in a while to come see so that they can really, you really have to, I can't emphasize how important that is. The people who are involved really have to be there and be part of that conversation. Thank you. That's it for that panel. Thank you so much.